Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine. Today I am going to discuss with you is about acute rheumatic fever, its microbiology, pathogenesis, and the complications. Let us look into what is acute rheumatic fever. Rheumatic fever is an inflammatory disease that develops as a complication of untreated or inadequately treated streptococcal sore throat infection caused by Group A Streptococcus. It is Group A beta hemolytic streptococcus, otherwise called Streptococcus pyogenes. So, the etiology is streptococcal infection. It typically follows a throat infection caused by Group A beta hemolytic streptococci. The pharyngeal infection is particularly prone to lead on to acute rheumatic fever in susceptible group. The bacteria contains certain structural proteins, especially the M protein, and this produces an autoimmune response. So you can say that acute rheumatic fever is an autoimmune disease attributed to abnormal immune response to the streptococcal infection. And the mechanism is said as the molecular mimicry. What do you mean by molecular mimicry? The antigens on the streptococci resembles the human proteins and trigger an autoimmune response, and this will be targeting at various tissues, especially the heart, joints, brain and skin. So these are the structures usually affected. Let us go into the pathogenesis. Already I mentioned pathogenesis is autoimmune reaction. The immune system mistakenly attacks the healthy tissues, particularly of the heart, leading to inflammation and later on recurrent infection. Recurrent episodes of rheumatic fever can lead on to valvular damage. So the antibodies produced as a streptococci cross-react with the human tissues. That is the pathogenesis. The clinical evolution, the patient can develop after an infection few days later, typically 2 to 4 weeks after streptococcal infection. So it is not a suppurative disease, it is a autoimmune process. The symptoms include fever, joint pain, otherwise called arthritis, skin rashes, and cardiac inflammation. Later it leads on to chronic phase. The manifestations of chronic disease is development of valvular damage. The valve may either become narrow or the valve may become stenosed. So it is called either, or it can lead on to what is called the stenosis of the valve. Example, the most common valve affected is mitral valve. It can lead on to mitral stenosis, aortic stenosis, or it can produce combination of stenosis and regurgitation. So you can get mitral stenosis and mitral regurgitation, or you can get aortic stenosis and aortic regurgitation. Sometimes combination of valve. The most common valve affected is, as mentioned, it is the mitral valve. How will you make a diagnosis of acute rheumatic fever? The diagnostic criteria is by the modified Jones criteria. So it has got major criteria and minor criteria. This has been discussed during the last session. Please check the video on this topic previously given. The point to be remembered is there should be 2 major criteria or 1 major plus 2 minor. In addition, there should be mandatory criteria. The mandatory things are, there should be evidence of recent streptococcal infection, like positive throat culture, antisepticalizing O. So this is how you make a diagnosis. The major criteria are polyarthritis, carditis, erythema marginatum, subcutaneous nodules, and rheumatic chorea. Minor criteria include fever, arthralgia if there is no arthritis, Elevated inflammatory markers like C-reactive protein, ESR, prolonged PR interval in the ECG. These are more evidence of previous rheumatic heart disease. Now we go into the rheumatic activity, their clinical assessment. It is mainly by the symptoms of carditis, arthritis, and the skin manifestations and chorea. Chorea is a late manifestation. So when the acute phase of acute rheumatic fever, you will not get the chorea. Chorea is usually a late manifestation. The arthritis is said to be a non-deforming. It will not produce deformity. It is a non-deforming arthritis. It affects the large joints. It is a polyarthritis. It is migratory. So these are the features. So it is a migratory polyarthritis. What do you mean by migratory? The pain lasts, for example, start on a large joint like knees. After a few days, while the joint pain is subsiding, the next joint gets affected. That is why sometimes called fleeting arthritis. Carditis is a pancarditis. You can get pericardium is affected, pericarditis features, can have pain. When the myocardium is affected, you get myocarditis. The patient may develop BP fall, hypertension, tachycardia, features of heart failure. Endocarditis. The acute phase, when the endocardial damage is evidenced by development of a new murmur. So these are the features of. Then the subcutaneous nodules, erythema marginatum. We will discuss the clinical features at a later time. The laboratory tests are elevated ESR and C-reactive protein. Age group is very important. It occurs in the younger age group. 5 to 15 is the typical age group. Let us look briefly into the complications. It produces valvular damage, already mentioned, scarring and dysfunction, especially the mitral valve and aortic valve. The complications are rheumatic valve disease leads on to rheumatic fever, leads on to complications as heart failure. You can develop arrhythmias. Most important, development of infective endocarditis. And this can lead on to thromboembolism and stroke. And these are the important complications. So, going to the infective endocarditis, this will be discussed in another session. Infective endocarditis occurs when the bacteria colonizes the already damaged valve. Usually the most common organism is the viridans streptococci. The details will be discussed in another session. Thank you.